We are honored to have Dr. Art Atkinson give one of the initial lectures of this course. Dr. Atkinson founded the NIH's course on Principle of Clinical Pharmacology almost 20 years ago. Dr. Atkinson received his undergraduate degree in chemistry from Harvard College in 1959 and his medical degree from Cornell University in 1963. Following residency at Mass General Hospital, he was a clinical associate in the Laboratory of Clinical Investigation here at the NIH's NIAID. He received his postdoctoral training in clinical pharmacology at the University of Cincinnati. In 1970, he moved to Northwestern University to start the clinical pharmacology program there. While at Northwestern, he and his colleagues set up the first U.S. hospital laboratory devoted to general therapeutic drug monitoring. In 1994, Dr. Atkinson joined Upjohn as a vice president for clinical development and medical affairs. Following the Upjohn Pharmacia merger, he joined the Center for Drug Development Science at Georgetown University. In 1998, he returned to the NIH as a senior advisor in clinical pharmacology to the director of the NIH's Clinical Center. Dr. Atkinson has received numerous honors and awards over the years. I know you'll enjoy today's presentation.
Thank you, Dr. Fig. I'm going to begin a two-part presentation on pharmacokinetics in patients requiring renal replacement therapy by talking about pharmacokinetics in patients who are undergoing hemodialysis. Well, you may think it's strange for a pharmacologist to be interested in hemodialysis, but as a matter of history, hemodialysis was first studied by John Jacob Abel, who actually was the first pharmacologist in the United States. And Dr. Abel published this paper way back in 1914, and he called it viviperfusion, and he had to build his own apparatus. He then had to make a leach extract to use as an anticoagulant. And one of the studies he did was to study the hemodialysis of a drug, salicylic acid. So you can see that a lot of what we're going to talk about has really its roots in the founder of American pharmacology. And although some investigators in Germany did some studies on hemodialysis in the 1920s, it wasn't until near the end of the Second World War that Wilhelm Kolff actually applied it to treat a woman who was in renal failure. And so he's really credited with being the first one to successfully use hemodialysis in treating patients. From the pharmacokineticist standpoint, the artificial kidney is the ideal eliminating organ. You can measure blood flow, you can measure drug concentrations going into the dialyzer, drug concentrations leaving the dialyzer. You can actually collect the dialysis bath fluid and see how much drug you've actually taken out. So previously, we've heard about renal clearance of drugs, and the observations we can make are somewhat more limited. We can measure the eliminated drug, obviously, and the concentration in blood going to the kidney. There are ways of measuring blood flow, but it's hardly ever done. And the same goes for the non-renal or hepatic clearance of drugs, where we really have only routine access to the blood concentrations themselves, and obtain hepatic clearance by subtraction of renal clearance from total clearance. So here are all the sources in an ARTA schematic of a patient on hemodialysis. There are convenient ports in the line to sample blood going into the kidney, sample blood leaving the artificial kidney. You can measure blood flow here and recovered drug. Now, as you know, the total elimination clearance represents the sum of renal clearance and non-renal clearance. And when we study patients on hemodialysis, we have a third elimination clearance to calculate. Dr. Gerhard Levy has said that for hemodialysis clearance or extracorporeal clearance to be considered effective, it has to be greater than 30% of the sum of renal and non-renal clearances. The essential point that isn't often considered is that these clearance estimates must be comparable, and we'll talk about that in just a minute. But first, I want to discuss a number of ways of thinking of hemodialysis clearance. And we've previously mentioned Professor Eugene Renkin in the context of the equation that he used to analyze transcapillary exchange. He also performed studies with the artificial kidney using the very same equation. And his equation neglected certain things like ultrafiltration and boundary effects, but it did take into consideration characteristics like the surface area of the membrane, the thickness, the porosity. Drug binding to plasma proteins could be considered, solute size, and diffusivity. And so if we look, for example, at two compounds, procainamide and its acetylated metabolite nappa, we can see that the ratio of the dialyzer permeability coefficients calculated from Professor Renkin's equation is very close to what we can measure in terms of the ratio of their free water diffusion coefficients. And Renkin published this figure in which he looked at the relationship between dialysis clearance and flow through the dialyzer. What you can see is urea, which has a very high permeability, has a clearance that is, for a while at least, quite close to blood flow measurements. As we get up to larger and larger compounds, for example, phenol red, once you get above, let's say, 150 mils per minute for your flow, you reach sort of a plateau in the dialysis clearance that can be obtained. So in a sense, this elimination is perfusion limited, and urea is more flow limited, if you will, in its clearance. Now, one of the problems we have in taking published literature data and applying it to an actual patient is that the study on which the literature is based may have been done with a different dialyzer than our patient is using. And one way of theoretically transforming the data between dialyzers would be to do a preliminary study and calculate the ratio of permeability surface coefficients for a particular drug and the standard compound, and then use the ratio to estimate what the dialyzer clearance would be for another dialyzer. But what needs to be selected is the appropriate standard compound. Maybe something like creatinine would work for that. But most of the kinetic studies that are done do not use Renkin's equation. There are merely empirical analyses. And there are two major approaches. The first is what I will call the recovery clearance. Here we're saying dialysis clearance is equal to the product of the dialysate bath concentration of drug times dialysate bath volume times the average concentration times the dialysis divided by the dialysis time. But you can also use the area under the curve of concentrations going to the dialyzer during that same time period. This is the gold standard for calculating dialysis clearance. Unfortunately, what's most often used is the AV difference method, which is based on the Fick equation. And here you have the AV difference divided by the arterial concentration going to the dialyzer times flow. These terms in parentheses we call the extraction coefficient. There's also an extraction coefficient in the Renkin equation, if you will. In both cases, clearance is flow times the extraction ratio. Now, there are two myths I'd like to disabuse you of in the dialysis literature. One is that you need to use blood concentrations when calculating blood clearance. Well, the fact is that usually plasma concentrations are proportional to blood concentrations. So if you're calculating this ratio, it really doesn't matter what you're using. The other thing that is much more serious is the so-called need to use plasma flow when calculating plasma clearance. Now, if we compare the recovery and Fick methods for calculating both blood clearance and plasma clearance, you can see that there's probably no problem when we're talking about blood concentrations here. But supposing now we're basing our clearance calculations on plasma concentrations, and that's how we calculate most of our pharmacokinetic clearances. Whether it's renal clearance, hepatic clearance, they're usually plasma clearances that we're calculating. And so if the plasma concentration is less than the blood concentration, that means the plasma clearance is going to be greater than the blood concentration. Well, the only way we can get the equivalent answer for plasma clearance from the AV difference method is to use a blood flow that is a flow term that's greater than blood flow. Okay? And so this is the major problem with using the AV difference method in calculating dialysis clearance, because remember, according to Levy, you want to judge dialysis efficacy on the percentage that dialysis clearance has compared to the renal and non-renal clearances. So those clearances have to be bona fide plasma clearances. And we can see here that the correct clearance, the correct flow, I'll call pharmacokinetic flow. In this case, the measured flow is 195 mils per minute. The pharmacokinetic flow is substantially larger, and we can estimate to some extent the correct pharmacokinetic flow by taking into account the partitioning of the drug into red cells. Because the drug in erythrocytes is by and large accessible to the dialyzer kidney. Well, what about the actual conduct of pharmacokinetic studies? And this is a topic of, I will say, increasing concern and interest. Chapter 6 in the Principles of Clinical Pharmacology book does cover this. More recently, there's another paper, and I would most of all direct you to the draft guidance that the FDA is preparing on the proper conduct of studies in patients with impaired renal function, and the draft guidance for the first time has recommendations for the conduct of these studies in dialysis patients, and by the way, does emphasize the importance of calculating recovery clearance based on the actual drug recovered. So all these things, recovered drug, concentration leaving the dialyzer, concentration entering the dialyzer, and flow, are accessible to direct measurement. And in conducting a study of this, you first of all have to start with the pre or post dialysis kinetics. And then you modify, in this case, a fairly simple 3-compartment model, by adding 2 more compartments. First of all, you have to have a compartment in which the drug is collected. And this is the direct way, the recovery method for calculating dialysis clearance. And the venous concentrations, the concentrations leaving the dialyzer, are calculated from this ratio. It's a proportionality. And that ratio really comes, it looks complicated, but it comes from a rearrangement of the Fick equation. And here you see how that rearrangement is accomplished. Let's carry this approach where we're taking all sources of data and building them into the pharmacokinetic model, something that is very rarely done. And when that is done, generally speaking, you'll find that during dialysis, the arterial and venous concentrations fall more than expected from the amount of drug that you recover. Similarly, after dialysis, this rebound in concentrations is less than you would expect. Now, this is what our dialysis kinetic model looks like, and the only thing that can account for both discrepancies is a reduction in slow intercompartmental clearance. And this is something that's hardly ever, I would say almost never, been observed, because nobody has ever conducted rigorous enough studies. It's not a trivial change. On the average I've found with this particular drug, there's a 77% reduction in that slow intercompartmental clearance during hemodialysis. Well, we'll get back to analyzing the reasons for that, but let's now move forward and say, of what clinical significance is this change, this reduction in slow intercompartmental clearance? And one of the obvious implications is it enhances the efficacy of dialysis in treating drug toxicity. And this is an actual case report of a 67-year-old woman who attempted suicide by swallowing 7 grams of procainamide. And she became lethargic and confused and hypotensive. Her kidneys stopped working, and she had a junctional tachycardia with intraventricular conduction delay. Hemodialysis was performed for 4 hours, and by the end of the second hour, her blood pressure was maintained without vasopressor therapy. And at the end of dialysis, she was alert and oriented, even though less than 1 gram of drug and metabolite had been removed. So she swallowed 7 grams. We've taken only less than a gram away, and she seemed to be better. Well, the procainamide clearance was increased by a factor of 2, NAPA almost 4-fold, the metabolite, and again, the amount removed was little, but look at the marked drop in plasma concentrations, particularly of the parent drug. We look at the pharmacokinetic parameters that were obtained in studying the dialysis kinetics in this woman. We see that initially she did have greatly prolonged elimination half-lives of both procainamide and NAPA, that the elimination clearance was greatly reduced, that dialysis significantly increased those clearances, but look, the distribution volume is much less. What is going on here? Well, usually when we estimate distribution volume, we give a dose of drug and we look at how much the concentration rises in the blood or plasma. In this case, though, we used the amount of drug removed and the change in concentration to calculate that distribution volume. Let me draw you a schematic of what we think is going on. The reduction in slow intercompartmental clearance is essentially putting a tourniquet between skeletal muscle compartment out here and the intravascular space. Okay, so in fact, we're dialyzing a much smaller distribution volume than we would if this intercompartmental clearance hadn't been reduced. And because the biophase, where the pharmacokinetic effects, where the pharmacologic effects are seen, is in more rapid equilibrium with intravascular space than, say, the skeletal muscle compartment, we can have a marked clinical improvement even though we've removed drug primarily only from 2 of the 3 compartments. So yes, the total extent of drug removal is compromised by this change, but it can accelerate the recovery of the patient and also the reduction in intercompartmental clearance persists for a while after hemodialysis, and that attenuates the post-dialysis rebound. Well, what is actually going on in terms of physiology to account for this? And again, we've previously discussed in our drug distribution lecture the Renkin equation. And so in terms of that equation, we can have a reduction in capillary blood flow. We can have a reduction in capillary permeability coefficient surface area product, or both of them can be decreased. So in terms of our capillary exchange model, that's what we think has to be going on. And again, I'll refresh your memory. Here is our 3-compartment model of inulin distribution and of urea distribution. We can use these marker compounds then to try to investigate what's going on. And here's a study in which the urea and inulin were given simultaneously, and inulin is not dialysable, but urea is. This is the arterial, and that's the venous concentration. And you can see that the intercompartmental clearances of both compounds decrease, although urea dialysis intercompartmental clearance falls much, much more than the inulin does. And that, as we've emphasized before, is because urea is more flow dependent in its dialysis, in its intercompartmental clearance than inulin. So right away, there's a clue that something has to be going on with flow. And in fact, when we use the Renkin equations to see what exactly is going on with flow, what you see here is that flow to the slow equilibrating compartment has decreased by 90%. And that decrease persists even in the post-dialysis period. But there is relatively little change in the permeability coefficient surface area products for either inulin or urea. Now, these are dogs that were studied that had intact kidneys. So their renin-angiotensin system is intact. The challenge, if you will, physiological challenge of hemodialysis is that the body thinks it's going into shock. So it does activate the renin-angiotensin system. You can see here plasma levels of renin that increase markedly during dialysis and remain elevated for some time. Now, I will contrast this situation where the renin-angiotensin system is activated with what happens in a study in which arginine vasopressin is activated. And on the y-axis here are the permeability coefficient surface area product changes. And you can see as the plasma level of arginine vasopressin increases, the permeability coefficient surface area product decreases. Now, this is markedly different from our dog study. And how is this accomplished? Well, first of all, one of my heroes, August Crowe, won the Nobel Prize and showed this slide, a cross-section of capillaries in the skeletal muscle of a cat. And what the bottom line is that only so many of these capillaries are open at a given time. The solid dots are closed, open circles are open capillaries. And so by regulating the number of open capillaries, the body has a way to regulate the permeability coefficient surface area product. It's the surface area, obviously, that's changed when you increase the number of closed or open capillaries or or reduce them. And the way that happens physiologically has been shown in microvessel studies that with angiotensin II, you're increasing post-capillary sphincters more than pre-capillary sphincters. So you're getting an increase in total peripheral resistance that keeps at the same time the capillary open. Whereas with arginine vasopressin and norepinephrine, you're closing only the precapillary sphincter and the capillary inside collapses. So that results in what we call capillary decruitment. So here's a system where you have, let's say, 8 open capillaries in the skeletal muscle bed. This is an animation of Crow's study. And you see if you reduce and now only have 4 open capillaries, oxygen has to travel a greater distance to get over to the tissues supplied by that capillary. Now, it's perhaps not surprising that if you decrease skeletal blood flow by 90%, some people might get cramps. The paradox is not everybody gets cramps. So how do we explain that in terms of the physiology? Well, because these patients have renal disease, that's where the renin is made. So they have an impaired renin-angiotensin system. And when that has happened, they may have a sympathetic nervous response to the volume distress of hemodialysis that's not modulated by the renin-angiotensin system. So they close down capillaries. And most of the non-crappers actually also have a defective sympathetic nervous system, so they don't close anything down. If you put them on the tilt table, their blood pressure drops precipitously. So they have a doubly impaired homeostasis than for volume stress. Well, that's the end of my particular section, and we'll continue to hear from more novel methods of extracorporeal drug removal that are less stressful to patients than hemodialysis. Thank you.
I am sad to report that since the filming of this presentation, Dr. Art Atkinson has passed away. Dr. Atkinson was one of the founders of the NIH Principles of Clinical Pharmacology course and was a true pioneer. His leadership in the field of clinical pharmacology will be missed.